So I'm particularly grateful to Claire Harrison and to people for the MPN Voice for this invitation, because I think that these days are very rewarding for us as doctors, but they are also much teaching to us. And I think that I will take several things that I learned here to my patients. We organize a day for the patients in Florence. This year will be the 8th edition around May. I'd like to invite you. You don't have a fast train to Florence, but I fear that you are not able to understand Italian language. Otherwise, you'd be very much welcome to our Patients' Day in Florence. So we are here to speak about prognostic models, and I would like to make a couple of points before starting giving you additional and, let's say, science information. The first is this definition of prognostic models are found in Wikipedia, more or less is what you can find in the website. So a prognostic model is something that can help you to reinforce the suspicion of a diagnosis, but in our in this speech, we will essentially speak about the use of prognostic models to predict something in a patient who already has a diagnosis of an MPN and who might suffer for some complications of this disorder. And it is quite important for us in this setting because these models can help the doctor to discuss with you about therapeutic options, about other procedures that should be done. And so these prognostic models might be of help for clinical decision making, especially when, as is the field of MPNs, there is no clear evidence of a benefit as compared to the risk of what you are doing. So sometimes these are very difficult decisions. We will speak about stem cell transplantation in myelofibrosis, and prognostic models are not laws, but can help the doctors who is expert in MPNs to take decisions. And I think that it is important to understand what is the final meaning and the final use of prognostic scores, because your doctor will use certainly the word score discussing about these aspects and also clarifying about the decisions. So for polycythemia vera and essential thrombocythemia, the main reason why we are using prognostic score is to be able to predict the risk of a patient to develop the main complication in terms of quality of life, but also of survival of these two disorders that is represented by thrombotic complications. We already heard Professor Babui this morning, and I will go through some additional details. And the second point is about the prediction of the evolution of the disease. So we have a very simple prognostic score for patients with PV and ET regarding the risk of thrombosis that has been already illustrated by Professor Babui, and this is based on two variables that unfortunately you cannot modify, that are age and a history of prior thrombosis. And these two variables, simple variables, allow to stratify patients in a low-risk category where the rate of thrombosis is low, but it's lower compared to high risk, but it's higher than in the normal population. In normal population, we can expect a value of about 1% patients here, and in the low-risk category, you see that we are about twofold greater risk. And this is about fourfold and more greater risk in patients with high risk PV and ET. So this helps us to decide whether, if you are a high-risk patient, it might be useful to use not only phlebotomies and aspirin, but also cytoreductive drugs. In case of essential thrombocythemia, the two variable simple models is equally effective as in polycythemia vera, but we have now a more modern score that is called the Ipsec Score. And this score, of course, uses the same two variables as our age and prior history of thrombosis, but it includes the cardiovascular risk factors smoking, obesity, hypertension, and so on. And for the first time being, it uses molecular variables. So we know that patients who have ET and are JAK2V617F mutated have an increased risk of thrombosis as compared to those who have the same disease, ET, but are not JAK2V617F mutated. And so by using these variables, we can identify three main categories of patients where their thrombosis rate, their expected thrombosis rate is, as you can see, different. And this will help us to make some decisions about how to manage this kind of disease. What about the progression of the disease? You know that with time, a proportion of patients with PV and ET may transform to secondary forms of myelofibrosis, and in rare cases, they might also transform into acute leukemia. So it would be very important to understand who is at higher risk to go into transformation, to progression of the disease. Unfortunately, we have to acknowledge that nowadays we don't have a single variable nor a combination of variables that can help us to say in a reasonable way that this patient is at a high risk of progression of the disease. This is said, we are of course all working about this, but at the same time we also have to acknowledge that disease progression nowadays is not an actionable target for treatment. There is no treatment that has clearly shown to be able to prevent disease progression in ET and in PV. So we are missing this information, but at the same time we could not use this information for managing patients as we are using for reducing the risk of thrombosis. What about myelofibrosis? Well, in myelofibrosis, the most compelling information we want to have is an estimate of the projected survival of the patient. Why this? Because we know that the only curative option for myelofibrosis is allogeneic stem cell transplantation. There is no drug that has been convincingly shown to cure the disease. There are good news about some treatments able to very likely prolong the survival, but cure can be obtained only with allogeneic stem cell transplantation. At the same time, this is a very difficult decision in a patient who is otherwise eligible for stem cell transplantation because the procedure has a significant risk of morbidity and mortality. And so it is mandatory for us to be able to identify the best patients for transplantation. That is the patient where the expected ratio between the risk and value of the procedure is satisfactory. We have now 3 different scores for stratifying patients, for assessing the risk of a patient in terms of survival, and these are represented by the IPSS, that means International Prognostic Score System, the DIPSS, that means Dynamic IPSS, and the plus variant of the IPSS. The IPSS is used at the time of diagnosis, so when you see a doctor for the first time, he will rank you according to the IPSS. The variables that the doctor will assess in you are the age, the presence of constitutional symptoms, that means weight loss, fever, and night sweat, the presence of anemia, of leukocytosis, that are the same variables used in the DIPSS score. The only difference is that anemia has a value of 2 in the DIPSS score, while the other variables have a value of 1. So at the end of the day, we just make a sum of the values of each variable. If you don't have, it is 0. If you have 1, it is 1. In the case of the plus variant of DIPSS, there are 3 additional variables that are thrombocytopenia, if you are dependent on red blood cell transfusion because of the extent of anemia, and if there are specific karyotypic abnormalities. So when making the final sum of these variables, patients may be stratified in 4 different risk categories: low, intermediate 1, intermediate 2, and high risk. And as you can see, we are able to have some idea about the median survival of the population of patients that fall in each of these categories. And we are we take particular care for patients who are in the intermediate 2 and high risk category, because if we consider the overall population of patients in these categories, their projected expected survival is less than 5 years. That, according to most experts, is a reasonable time to think about the opportunity of allogeneic stem cell transplantation. And this is supported by some studies, in particular this one, where you can see 2 different curves, one labeled in yes, red, that is patients who underwent stem cell transplantation, no, patients who were managed with conventional therapy. And so you can see that in the 2 upper squares that point to patients with low and intermediate risk category, the yes curve is down. So this means that there was no survival advantage in these patients as compared to those who did not receive stem cell transplantation. The converse is true for the lower squares, where you can see that the yes curve is upper. This means that patients who received stem cell transplantation had better survival as compared who did not receive stem cell transplantation. So this is a way to translate into clinical practice the value of the prognostic score of IPSS and the IPSS. But now we are starting to make something more, because those scores were built up only with clinical variables. Now we know much more about the complexity of the disease, and so we have started to ask whether the genetic basis of a single patient might help us in making better prediction. So you well know that there are 3 mutations that label most of the diseases, and these are the mutation in JAK2, in MPL, and in calreticulin. These mutations are shared in a different way by the different diseases. Virtually all patients with PV have a JAK2 mutation. About 60% of those with ET and myelofibrosis have the JAK2 mutation, and then about 20-25% of ET and myelofibrosis have a calreticulin mutation. Less than 10% have a mutation in this other gene that is called MPL. So knowing the genetic characteristic of a patient, we have started to introduce these variables in clinical scores. But we know that these mutations are not the only one a patient can have. So there are other mutations that are not specific for MPNs, but can be found in other hematological disorders, so we can simply call them as other mutations. Probably the most frequent you can hear about are those highlighted in red. And these contribute to the complexity, to the genetic complexity of a disease in a single individual. So, the 3 main mutations, we learn a very important lesson for the most recent studies. Patients who have a calreticulin type 1 deleted calreticulin gene has a favorable outcome of his myelofibrosis as compared to the other mutations. This is the first lesson. The second lesson is that a patient who lacks some specific mutations that are called altogether high risk mutations, a patient who lacks these mutations has a favorable outcome. So now we have something that is more intrinsic to the disease in terms of mutation as compared to the other variables, And we have started to add this information to the clinical scores. And in particular, we have recently developed, and will present it shortly, a new scoring system that is specifically addressing the question based on the molecular characteristic of the patient, if there might be some advantage in proposing to the patients to undergo allogeneic stem cell transplantation. However, we have to understand, and this is coming back me to the beginning of this speech, that these scores have been developed on cohorts of patients. That means hundreds of individuals. And this does not translate in an easy and an immediate application of the information of the score to a patient. And so we think that beyond genes and beyond scores, even if we are moving towards personalized medicine, we have to consider the individual. And I think that this has been very well expressed by the journey of Emily in the morning session. Thank you for your attention.